Module T, Dementia and Alzheimer's disease. We're going to talk about what dementia and Alzheimer's disease are. We're also going to talk about delirium and describe our role as nurse aides in caring for the resident with Alzheimer's. Dementia is usually a progressive condition marked by the development of multiple cognitive deficits such as memory impairment, aphasia, and the inability to plan and initiate complex behavior. Now, something that you might not know is dementia. Think of it as an umbrella term because there are different causes of dementia. You've got Alzheimer's disease, vascular dementia, dementia with Lewy bodies, and then you can have mixed dementia, which is just a combination of some of those. Alzheimer's disease is the most common cause of dementia, and it's thought to be caused by clumps of proteins in the brain. Vascular dementia can occur when blood circulation to the brain decreases, and this can be as a result of a stroke or some other problem. When the blood in the brain decreases, it's going to cause damage to the vessels in the brain. Dementia with Lewy bodies also has to do with protein. It's deposits of protein that develop throughout the brain, causing damage to nerve cells, eventually killing these nerves over time. We are going to focus on Alzheimer's disease since it is the most common. Alzheimer's is a progressive disease, as mentioned. You will see gradual decline in memory, thinking, and physical ability over several years. In fact, time from diagnosis to death can span anywhere from 3 to 20 years, which is a big span of time, but the average lifespan is 8 years. Alzheimer's disease progresses in 7 stages, and you do need to know these 7 stages and be able to differentiate between them. The first stage is no impairment. So the Alzheimer's disease is present, but it is not evident yet. There are no memory problems. Stage 2, this is very mild decline. This is when you'll have minor memory problems, but it's very unlikely to be noticed even by close family members. Might be things just like losing things around the house, misplacing items. Stage 3 is mild decline. This is when family and friends may start to notice some cognitive changes. We may have difficulty organizing and planning, difficulty finding the right word during conversation, or difficulty remembering names of new people that we meet. Stage 4 is moderate decline. This is when we start to see our family members or friends having difficulty managing their finances, difficulty with simple math, and poor short-term memory, like not remembering what you ate for lunch that day. Stage 5 is moderately severe decline. This is when we are still able to maintain a lot of functionality. We usually can still bathe and toilet ourselves independently. We still know our close family members, but we may start to have difficulty in dressing appropriately or inability to recall simple details such as our own address or telephone number, and there is some significant confusion in this stage as well. Stage 6 is severe decline. This is when we are going to need more constant supervision, usually requiring professional care. Confusion and unawareness of our environment and our surroundings makes it more difficult to care for ourselves, right? We have an inability to remember most details about our personal history even, and we may see loss of bladder and bowel control in this stage. We also start to see changes in personality in stage 6, possible behavior problems, and like I mentioned, assistance with bathing and toileting. This is when we may start to see wandering as a behavior. Stage 7 is very severe decline. This is the final stage of Alzheimer's disease when the person is nearing death. Often these people will lose the ability to communicate or respond to their environment. Sometimes they'll utter words or phrases, but they might not always make sense. They have no awareness regarding their condition, and they need assistance with all activities of daily living. They may even lose their ability to swallow. Again, those are the 7 stages of Alzheimer's disease, so make sure you're familiar with those. I mentioned delirium. So delirium is a state of sudden severe confusion, and it's usually reversible. This can be triggered by an acute illness or change in physical condition, and it can be life-threatening if it's not recognized and treated. Some symptoms of delirium, again, that's that rapid decline in cognitive function or our ability to think, restlessness, sometimes altered levels of consciousness, hallucinations and delusions, and suspiciousness. If we suspect delirium, we want to stay with the resident and call for help. When someone is suffering from delirium, we need to make sure that as caregivers we are staying calm, keeping that normal volume, use the resident's name to try and get their attention and orient them, speak clearly and in simple sentences, and reduce distractions like a loud TV or a bright room or other people in the area. Now, dementia and delirium get confused a lot. So remember again, delirium is a sudden, severe onset and it's usually reversible, whereas dementia is progressive and irreversible. But it's important to know that a resident who has dementia can experience delirium. Again, if we notice any sudden change in behavior or a sudden increase in behaviors that we typically associate with dementia, get the nurse, because the patient with dementia may be experiencing delirium at this time. So we have a couple slides here with some key terms that we need to make sure we know. Cognition, that's our ability to think quickly and logically. Confusion is an inability to think clearly, causing disorientation and trouble focusing. Irreversible is a disease or condition that cannot be cured. Onset is the time when signs and symptoms of a disease begin. Progressive is the way a disease advances. Dignity is respect and honor. Independence is our ability to make decisions that are consistent, reasonable, and organized, and being able to perform activities of daily living without assistance. Quality of life is our overall enjoyment of life, and respect is being treated with honor, show of appreciation, and consideration. Every human being is unique and valuable, and every human being deserves understanding and respect. Now, someone with dementia, it basically does not eliminate their right to these basic human needs just because they have dementia. And person-centered care, which we've talked about before, maintains and supports the person regardless of the level of dementia to, again, maintain that respect, dignity, and quality of life. Residents' abilities, interests, and preferences should still be considered when planning activities and care with the patient with dementia. And as the disease progresses, we have to adjust what we're doing in order to maintain dignity. So it's important for the staff to know who the resident was before the dementia started to be able to give the best care possible. An individual's personality is created by his or her background, and this can include our race, our nationality, our religion, ethnic group, culture and social practices, how we were raised as children, our career choices, family life, and hobbies. We always want to encourage residents to participate in activities of daily care, but when we're dealing with residents with dementia or Alzheimer's, we do want to try and avoid situations in which we know the resident is going to fail. It doesn't mean we don't want to maintain this independence as long as possible, but we can assist as needed. We don't want the residents to feel humiliated because this is disrespectful and degrading, and it can also increase the likelihood of disruptive behaviors that sometimes come along with dementia. To promote independence, if our residents with dementia need assistance, that's fine. So it's better to do things with the residents still rather than for them. We have to remember to allow time for residents to express their feelings and understand why they're feeling the way they are, provide emotional support. Long-term care facilities must provide care for residents in a manner that promotes maintenance or enhancement of each resident's dignity, respect, and quality of life. Residents with Alzheimer's disease often experience problems making their wishes known and in understanding the spoken word. So communication over time is going to become more difficult with our residents with dementia and Alzheimer's. Some changes that we commonly see in the resident with Alzheimer's are the inability to recognize words or phrases, inability to name objects. We see them using more general terms instead of specific words, again, because they just can't think of that correct word. Sometimes they'll even get stuck on an idea or a particular word and repeat it over and over again. It's really easy for the resident with Alzheimer's to lose their train of thought. Sometimes they will use inappropriate sometimes even rude or disrespectful or insulting language during conversation. Over time, their comprehension of the written word will decline, and eventually will lose their ability, to write. Sometimes when we have a resident who has a different native language than what they're currently speaking, they'll actually revert back to their native language or combine the two. Over time as well, we see a different decrease in the level of speech and the use of select words. Sometimes those nonsense syllables, like I mentioned, and they become more reliant on gestures rather than speech because of all of these issues. So our role as nurse aides, well, there are several components that we can do when assisting the resident with communication. Of course, we need to be patient, offer comfort and reassurance, give them time to respond if we ask a question or make a, say like, let's head this way, we're going to head to the right. Give them time. Avoid correcting, avoid arguments. If a resident is having difficulty expressing themselves or finding the right word, it is good to offer a guess at what they're trying to say. Limit distractions, of course, and encourage nonverbal communication to aid in this and communication between staff and patients. So the nurse aide's method of communication with the resident with Alzheimer's is critical. Utilizing some of the following techniques that we're going to talk about here can help to decrease frustration for both the resident and for the nurse aide. It's going to be important to make sure we obtain the resident's attention before we start talking. So use their name, make sure they're looking at you, try and gain as much focus as you can. Make sure we are, trying to always present ourselves in a calm and gentle way. If the conversation is interrupted for some reason, let's say you have to run out into the hall for an emergency situation, when you come back, know that you're going to have to start over from the beginning. And if we do need to repeat ourselves at any point, be patient with that, knowing that when we can use the same words or phrases as we've used in the past, this is really going to help. Try to slow down. Don't act rushed or impatient. And again, making sure we're speaking clearly and use short, familiar words and sentences and avoid these long explanations. If we're working on a task or giving instructions for a task, we want to be as simple and to the point as possible, as mentioned, and we want to break tasks into small, simple steps and instructions. Oftentimes, if we can demonstrate something for our Alzheimer's patients and then let them show it back to us, that's going to be super beneficial. Again, using some nonverbal cues like pointing or gentle touch can really help as well. We also can encourage the resident to point or use images to help communicate. Let's see, some other communication strategies with the resident with Alzheimer's or dementia. Listen carefully to what they're saying, again, giving them time and minimizing distractions. Let's see. Oh, keeping choices at a minimum. That's another good idea. So, choice is really important. We always want to give our resident choice. But if we give our resident with dementia or Alzheimer's too many choices, that can be overwhelming. So usually one choice, or two choices, I should say, is the best option. Would you like this or that? Not listing out 4 or 5 different choices. Let's see. And again, I've mentioned this already, but using like pictures or books or boards can be really helpful and help decrease frustration for the resident and for the caregiver. We always want to make sure that we are identifying ourselves to the resident, being calm and supportive, paying attention to their cues, their body language, and what they're saying verbally. Speak slowly and clearly, use those simple words and short sentences. Remember also too, a lot of this is repeat, but I don't think I've said this yet. Always ask one question at a time. So don't ask multiple questions. Ask one, wait for the response. Offer assistance as needed. And of course, we have to be patient, flexible, and understanding. All right, so we are going to talk, these are some common behavior issues that we see in our Alzheimer's and dementia patients, and we're going to go through each one of these individually. So behavior is any observable, recordable, or measurable physical activity. People with normal brain function have the ability to control their responses, but people with Alzheimer's disease and dementia have lost a lot of the ability to control their responses. We've said this a lot in class. A behavior is a response to a need. So Alzheimer's patients are frequently unable to express their needs because of cognitive losses. So we have to be attentive to gestures and clues that the resident does. Every behavior is a response to a need or a situation. If we pay close attention to our residents' gestures, their conversations, it may give us clues to what triggers are, because sometimes there are certain triggers that trigger a behavior, and if we can learn what they are, then we can hopefully prevent the trigger or be able to quickly remove it. Let's see. Triggers can be environmental, physical, or emotional. Environmental triggers might be there's a lot of people around, we've rearranged their furniture, we've changed their daily schedule. Physical, they're on a new medicine, they have an infection, or they're in pain. Emotional triggers may include a reaction to a loss, feeling frustrated, a past life event, or just part of their personality, or personality changes associated with Alzheimer's. So some effective behavior management strategies, of course, identifying the trigger, understanding the trigger, and then adapting the environment to resolve the behavior. So changing the environment, like reducing excess noise or activity, providing comfort measures like pain medication or rest, these may all help to reduce unwanted behaviors. We have to remember that interventions have to meet the needs of the resident while still maintaining respect, dignity, and independence. Behavior control also assists in reducing the use of restraints, which we talked about in a previous lecture. And they also decrease abuse and neglect and increase satisfaction for family, patients, and caregivers. So we're also going to talk about these different common behaviors. I think some of these were on the other slide, but we're going to talk about these individually. All right. So wandering, wandering is a known and persistent problem behavior with a high risk for safety. Safety risk factors may include falls or elopement, also physical attack by other residents because they feel threatened or irritated. Residents wander for several reasons. It may include that they're trying to fulfill a past duty, like going to work. It might just be because our Alzheimer's patient feels restless. It may be because they're confused and disoriented and they can't find their room or the bathroom or the dining hall. And it may also be a reaction to a changed or new environment. So maintaining safety is the main objective when it comes to wandering and caring for the wandering resident. We can do this. It doesn't necessarily always mean we have to stop the wandering, but we can establish a regular route. We can accompany them. We can make sure that they stay hydrated, provide rest areas. We can attempt to redirect their attention to other activities, and we can determine if the behavior is due to an environmental stress that we can fix or resolve. Sundowning is a behavioral symptom of dementia that refers to increased agitation, confusion, and hyperactivity that begins in the late afternoon and builds throughout the evening. Sundowning, if it's going to happen, it's going to happen, but we can kind of decrease the symptoms of sundowning by encouraging rest times throughout the day and bulking our activities for the early morning hours, saving more like relaxing and quieter and less energetic activities for the late afternoon. So inappropriate sexual activity is another behavior issue we may see with the Alzheimer's or dementia patient. This could be offensive or inappropriate language, public exposure, offensive or misunderstood gestures, and we can intervene by, first of all, making sure we're always maintaining respect and dignity, removing that resident from public situation and escorting to the bathroom if they need to, and or redirecting their attention to a more appropriate activity. Agitation in the Alzheimer's and dementia resident can occur for a variety of reasons. Safety is going to be a key thing here, while maintaining dignity and respect. Some interventions, giving the residents space, right? Don't crowd them. Either remove other residents from that space or take your agitated resident to another area. Maintain that calm and normal voice. Don't rush residents. Limit stimulation. Avoid confrontations, and also avoid sudden movements that are out of the resident's field of vision. We've talked about this when we talked about de-escalation, and some of those same things apply to the resident with dementia and Alzheimer's. Disruptive verbal outbursts are one of the most persistent behaviors in a long-term care facility, and they can include, residents just talking to themselves, making negative remarks to other residents or staff, screaming, swearing, crying, shouting, or just requests for attention. Anger and aggression are often the visible symptom of anxiety and fear, and that's really worth repeating. So, anger and aggression are often the visible symptoms of anxiety and fear. So, if we focus our interventions on reducing anxiety and fear, we're going to hopefully reduce the behaviors of anger and aggression. So, we want to reassure our residents that they're safe. We can try redirecting their attention to a different activity, assist them to toileting or eating or drinking, and again, helping them get to a quiet area with decreased stimulation. If these aggressive behaviors or agitated behaviors threaten other residents or the staff or themselves, we need to get help and make sure the nurse knows as well. All right, 41. So catastrophic reactions. These are emotional, are catastrophic reactions are basically out of proportion responses to activities or situations. Emotional, environmental, physical triggers can all cause catastrophic reactions. And can be warning signs that a catastrophic reaction is possible. That would be sudden mood changes, sudden uncontrolled crying, increased agitation, increased restlessness, or outbursts of anger, whether they be physical or verbal. If someone is having a catastrophic reaction, some of our interventions, again, similar to an agitated resident, being calm, speaking softly and gently, protecting the resident, yourself, and others, removing the person from whatever stressful situation is going on. Don't argue with the resident. Redirect their attention and change whatever activity may be causing the reaction. We definitely don't want to argue with residents when they're having a catastrophic reaction. We don't want to treat them like a child. If we ask too many or too complicated questions, this is just going to increase the reaction. We can, on the other hand, maintain that calm and non-controlling attitude, speak softly and calmly, ask one question at a time and wait patiently for the answer. Use simple one-step commands and positive phrases. Again, avoid crowding the resident and provide distractions. So let's talk a little bit, shift gears here now to activities with the Alzheimer's and dementia patients. The goal in the care of residents with Alzheimer's disease is to give the support needed so they can continue to participate in the world around them to the best of their abilities. So we need to focus more on the fact that a resident is involved in activities, involved in care, and that the resident is satisfied, more so than do they complete the activity successfully or do really well. More importantly, again, is are they involved and satisfied? We can break activities down into two categories: doing activities, which are activities that just keep a person busy, and those are appropriate at certain times and for certain situations. But even better is when we find meaningful activities. These are activities that have value to the resident with dementia. Activity-based care is focused on assisting the residents to find meaning in their day by doing these meaningful activities rather than just these doing activities. So there are some basic principles of activity-based care. Again, focuses on giving caregivers the tool to create chances for the resident with dementia to be successful. in both activities and relationships with other people. It uses any daily activity that can be broken down into individual sequential steps that the resident can accomplish. And activity-based care works with the remaining abilities and strengths that the resident with Alzheimer's has, and again, shifts the emphasis away from the resident's disabilities and impairments to what they can accomplish. We, of course, have to adjust all activities based on the resident's ability level, and this is going to change over time. This is going to depend a lot on the caregiver's interest and desire to create these opportunities for the resident or the family member. And activity-based care rewards the resident's attempts at participating and provides them a sense of being capable and alive and having meaning. When we're dealing with Alzheimer's and dementia patients, the timing of activities is really important and really individualized. So these activities have to be done at that individual resident's prime time, because every individual with Alzheimer's and dementia is going to have a better time of day for them. It's really individualized. And when we find that prime time, we want to do these activities in a set routine way because it increases participation and satisfaction. It's important to keep in mind that cultural environment can have an effect on these different activities. So we want to promote a positive environment. We want to include the resident, make them feel included. We can include families as well in some of these activities, which can always be beneficial. So something that we need to talk about when we talk about residents with Alzheimer's and dementia is stress and burnout. So providing care on a daily basis for residents with Alzheimer's and dementia is extremely stressful. This population of residents may be more prone than others to becoming victims of abuse or neglect. Because of this, nurse aides that deal with Alzheimer's and dementia residents must take additional precautions to ensure they do not overreact or react negatively to resident behaviors. Regardless of the cause, nurse aides must take necessary steps to ensure that they do not react inappropriately to the resident's behaviors. Frustration on the nurse aide's part can lead to negative, harsh, or mean-spirited statements, physical abuse, emotional abuse, verbal abuse, or neglect. Nurse aides must always remember that statements and behaviors of residents suffering from Alzheimer's or dementia are beyond their control and not to take it personally. The usual profile of an employee who is subject to burnout: you take work very personally and seriously. You work over at the end of your shift on a regular basis. You work extra shifts. You take on extra projects. You have really high expectations for yourself, sometimes unrealistic, and you tend to have a perfectionist attitude. Signs that you are burnt out: you no longer enjoy work. You become irritable with residents and coworkers. You fear failure, inadequacy, or job loss. You feel overwhelmed. You view work as a chore, and you have frequent complaints of illness. There are strategies to use to assist in preventing burnout, and this includes maintaining good physical and mental health, getting adequate amounts of sleep, remaining active with family and your community, maintain a separation between work and personal, and maintain a good sense of humor.